I'm Jerry Bloom. I'm at the Institute of Development Studies in Brighton, which is on the English Channel in Britain. We now have 54 participants attending. This webinar is part of a set of activities that's linked to a symposium that will be organized at the International Health Economics Association in Sydney in early July. These symposia have been organized since 2009, and the aim is to enable and encourage and disseminate high-quality research on the performance of health markets and on strategies for improving access to safe and effective services for the poor. The responsibility for organizing the symposia has shifted between institutions, and the Future Health Systems Consortium is responsible for organizing the 2013 symposium with financial support from the Gates and Rockefeller Foundations and the SHOPS project. We're organizing this webinar series really as a run-up to the symposium in Sydney with three main aims. First is to just encourage interest in some of the issues in advance of the symposium. We'd like to deepen discussion and debate on some specific issues where there is a lot of research finding or a particular policy relevance. And we wanted to widen opportunities for broader participation from people who won't be able to get to Sydney. So that's the aim of this webinar and the others. The webinars are facilitated by the Future Health Systems Consortium, but responsibility for organizing them is moving between different institutes. And this first webinar is organized by the Center for Health Markets Innovation. We've publicized it widely to involve a wide audience. The next webinar will be held on the 7th of March, and it will be entitled Shaping the Future of Health Markets, Reflection from a Meeting in Bellagio. Registration will open soon. Okay, the title of this webinar is Harnessing Informal Providers for Health Systems Improvement. We've picked this topic mainly because of its great importance of informal providers as sources of advice and drugs for poor people in many low and income countries, and because there's a growing body of evidence on who uses them and the services they provide. Increasingly, a variety of innovators and social entrepreneurs are testing strategies for improving their performance, and governments are slowly recognizing their importance. We would see one of the big questions for this webinar and for the symposium is whether the engaging with health informal providers creates an opportunity for governments to increase access to effective and affordable services in their attempts to move towards universal health coverage. I will briefly outline some work by the Future Health Systems Consortium on informal providers. We've undertaken, over the past 5 or 6 years, we've undertaken case studies in India, Bangladesh, Nigeria, and China. We've reported on our findings in a book we published recently entitled Transforming Health Markets in Asia and Africa, and there's a picture of the cover on your screen. We've collaborated with the Center for Health Markets Innovation in a program they're leading on informal providers. And we helped organize an exciting meeting in Bellagio last December on engaging with health markets, and we produced a briefing note with the title on your screen. You can download this briefing note by visiting our website. And finally, we're building networks and increasingly interested in testing interventions that work and can be taken to scale. A couple words about the organization of the webinar. It will be led by the Center for Health Markets Innovations, and Gina Lagomarsino will introduce the webinar in her presentation. And followed by Meenakshi Gautham, who will speak in more detail about her findings in India. On the side of the screen, you should see a control panel with a chat function. Participants are invited to send written questions or comments to the meeting organizer by instant message. We suggest you send it to the organizer. If you send your questions to the entire audience, they will be public. We will remove any duplications and select questions to pose to each presenter. We will try as much as we can to represent all the issues and questions you raise. The aim of the webinar is to stimulate discussion and debate about the role of informal providers. And just one note before I pass over to Gina, this is the first webinar, and we'd really like your help in improving the way we organize them. And we will ask you to complete an evaluation form. Now I will ask Gina Lagomarsino to introduce the webinar.
Hi, this is Gina Lagomarsino from Results for Development, and we also lead the Center for Health Market Innovations. The Center for Health Market, and I must say actually that we're quite delighted to be working with Jerry and his team at the Future Health Systems Consortium. The Center for Health Market Innovations' goal is to improve the performance of the healthcare marketplace for poor people around the world so that they can get better access to care at an affordable price and at a higher quality. So when we were setting out to identify a research agenda when we first launched the center back in 2010, we considered a number of topics, but we decided that informal providers really was the topic that we should focus on because, as Jerry mentioned, they make up such a huge portion of the healthcare system in so many countries, and yet they've been largely ignored by researchers and the general global health establishment. So we wanted to try to better understand what they were doing so we could learn how we might be able to engage with them more to improve care for the poor. Now, to begin, we actually brought together a small working group of people that were already working on this topic, primarily researchers, some practitioners, and this really fabulous group began starting to talk about some of the big issues related to informal providers. At the outset of this, we also really wanted to better understand what was already known. So we commissioned a literature review to look at what the findings from previous studies had been. And for this, we decided to work with the Global Health Group at the University of San Francisco with the team led by Dominic Montague and May Sudanarset. So one of the first, and then this group did meet several times over the course of the last several years. One of the first major discussions that the group had was on the definition of informal providers. And for those of you who work on this issue, you, I'm sure, recognize that this is a difficult group to define. It includes, traditional birth attendants, village doctors, drug sellers, traditional healers. So it's a little bit hard to actually clarify who they are, but we had a good discussion about this. And we decided that there were three major characteristics of informal providers. Number one, their business model. They're chiefly entrepreneurs who are collecting payments from patients, not institutions, and usually this payment is in cash. Secondly, they possess little or no officially recognized training. We'll talk a little bit more later about the kind of training they do get, but they don't have officially recognized training typically. And then thirdly, they largely operate outside effective regulation by either governments or other groups that may provide oversight. So it's not potentially a perfect definition, but it was the one that the group came to after a lot of discussion and after it was proposed by the folks at UCSF. Now, I'm delighted to report that the literature review that was completed by the folks at University of California, San Francisco is actually going to be published tomorrow in the journal, the online journal PLOS One. So you can go read all of the findings as of tomorrow, but I just wanted to touch on some of their conclusions based on the previous literature. Not surprising to those of you who work on this topic, the size of the informal provider sector is quite large. The scope is fairly broad. It's varied. It really varies by provider, of course, but it can include everything from maternal and child health to malaria, reproductive health, HIV/AIDS, and then clearly a lot of drugs are being sold and basic primary care being delivered by informal providers. Information about quality has been quite limited in the past, but there's definitely evidence that quality is poor. And finally, the reasons for the use of informal providers, primarily convenience, easy access in terms of location as well as working hours and relatively low price. So that was, the working group had the benefit of being able to see the preliminary findings of this lit review about 1.5 years, 2 years ago. And based on that, we decided that there was a lot more that needed to be known about this group. So we decided to commission several studies to look at this in detail in a number of countries, in 3 different countries. And the questions that we wanted to have asked were things like, who are really these informal providers? What's a typical profile of an informal provider in various markets? Where do they actually get their information? Who's influencing them? Can we get any more information about the level of quality of their services? And what are their referral patterns with formal providers? Do they have any interaction with them? Those were some of the main questions we had. We put out a call for proposals, and we ended up selecting 3 teams in 3 different countries. One team was led by Nabil Ashraf Ali in Bangladesh at ICDDRB. Another team was led by Professor Oladimeji Oladepo at the University of Ibadan in Nigeria. And then finally, Dr. Meenakshi Gautham led the team in India. And in a few minutes, you're going to hear a lot of really fascinating findings from India. But before we jump there, I wanted to just give you all an overview of some of the themes that came out of these 3 studies. So a first theme that really emerged from the work in these 3 countries was the relationship that informal providers have to their communities. We did note in advance that they are considered convenient and inexpensive, but really what came out of these studies, which was very interesting, was just how strong a relationship they have, just how strong their ties are with their community. Most of them are locals. They are practicing very close to the community where they were born and raised. Often they've had practices for many years, sometimes decades. Interestingly, they're often considered the social elites in their communities. While they may not hold advanced degrees, they actually appear to be relatively well educated, most of them, with the vast majority having completed secondary school and beyond. And in every country, in all 3 of the countries we looked, the number of years of education of informal providers was much higher than average in their country. Now, the elite medical establishment and some of us in global health may view informal providers as quacks or untrustworthy imposters worthy of little respect, but this does not appear to be the way they are viewed by their communities. They're not necessarily thought of as the provider of last resort. And that's not the way they feel about themselves either. Many of them, when they were interviewed, they felt like theirs was quite a noble profession. So it's clear that these providers in many countries, especially India, which we'll get into more in a few minutes, are the first point of care for many of the poor, and they're extremely trusted by their communities. So this does really beg the question. You know, many people, I think, assume that if you created a better kind of formal health system around them and put more public providers in villages, that people would automatically transfer over and begin seeking care from formal providers. But I think that the finding about the close-knit relationship with the community and the high degree of trust raises the question about whether that really will happen. Will people change their care behavior? So a second theme that came out of these 3 studies relates to the training that informal providers receive. We know that they have very little formal training, but where do they get the information that they actually use? It's often assumed that they don't have much, or that they mainly are engaging in traditional medicine rather than Western allopathic medicine. But the study authors found that most informal providers do have some medical training, but there's a lot of variation in the duration and formality and content of that training. There have been some that have taken commercially offered courses. We'd love to find out more about what these courses are like. We don't know enough about them yet. We also recognize that a number of them have been trained as community health workers in the past, and they've taken other kinds of training, but then they've become informal providers over time, so they sort of revert away from being community health workers under some either government or NGO system. For example, in Nigeria, about 85% of the patent medicine vendors studied had previous training on diseases like malaria and diarrhea. In Bangladesh, 91% of village doctors surveyed reported that they'd received some professional training. And interestingly, in some of the study sites, we found that a number of the informal providers had actually had apprenticeships with formal providers. So we found that they can and do get some training. And there also was a finding in a number of the sites that the informal providers are eager for more training. So this raises the question about how might better training be provided to these folks. A third theme that came out of the studies was related to quality of care. And as we expected, we found that informal providers engage in a number of incorrect and potentially quite harmful practices. For example, there's often inadequate testing before diagnosis. This was something that came out strongly in Nigeria in the case of malaria, where rapid diagnostic tests are rarely used, and that's the standard of care there. We saw a lot of rampant overprescription of antibiotics in some markets. This was particularly apparent in Bangladesh, where virtually every illness seems to be treated by antibiotics. We saw inappropriate injections, which is particularly pronounced in some parts of India. And there's even were examples of informal providers inappropriately administering oxytocin to bring on labor in pregnant women, which can be quite dangerous. And of course, there was just the basic polypharmacy, or just wasteful overprescription of many types of medicines for many patients for a single episode. However, there was also some evidence, and Meenakshi will talk more about this in India, that informal providers do offer some appropriate care, and they have maybe incomplete but some knowledge of proper protocols, and as a result, they do sometimes provide the right kind of care. And for example, in Nigeria, 60% of patent medicine vendors knew that ACTs are the correct first-line treatment for malaria, and they're prescribed about half the time. So this evidence suggests that even though they may have limited knowledge, they can learn about some protocols. However, when they learn, and even when they do have the right knowledge, they're very influenced by their market, including consumer demand. Even if a provider knows that he should be providing ACTs, if the patient is requesting chloroquine, they're probably going to prescribe chloroquine. Or if a patient wants an injection, they're probably going to give an injection. They're also highly influenced by supplier pressures, what the pharmaceutical companies are pushing, and of course their own desire to earn a living. So just training, just getting knowledge about what the right practice is doesn't necessarily mean that they're going to change their behavior. And as an aside, even though these studies did not compare informal providers to the formal sector, I would urge you all, if you're interested in this topic, to check out a study that was recently published by Jishnu Das in Health Affairs, which did actually make comparisons in quality using standardized patient methodologies between public and private informal and private formal providers. And he found that there was not a whole lot of difference in quality across those three groups. So that research suggests that even if you could get patients to leave their trusted informal providers and go to a public clinic or a qualified doctor, you might not really improve the quality of care all that much. Very interesting new evidence there. So a fourth theme that came out of these studies was related to the degree of interaction with the formal system. And what we found that was in most markets, these informal providers really aren't operating in complete isolation. They're getting medical information and supplies from pharmaceutical representatives. In Bangladesh, we found tons of medical representatives that were constantly talking to the informal providers. They're also getting information from qualified doctors, sometimes through apprenticeships and sometimes in the course of referrals. And we found in some markets that they actually are making quite a few referrals to formal doctors, and they may be paid commissions or given gifts, and I think Meenakshi will speak more to that in India. So this actually raises some interesting questions about whether some of these relationships might be formalized and whether that could potentially lead to better oversight and improved quality. A final theme that came up was on the degree of organization among the providers themselves. And across the 4 study sites, there was a big range. It ranged from, in some places, like in Bangladesh, pretty unorganized, some hostility from the government. But in other places, we began to see a bit more organization and even some recognition by the government. In Nigeria, the Patent Medicine Vendor Association has organized strongly and fought for the rights of patent medicine vendors against the interests of licensed pharmacists, and they've actually won some court cases. And similarly, Andhra Pradesh, India, there's some interesting things happening in terms of organization of providers and recognition by governments, which Meenakshi will talk about. This actually, some of these findings made us question whether these providers and these locations could even still be considered informal. Did they meet our definition? But it certainly raises the questions about whether raises the question as to whether there's opportunities to cultivate more organization and more recognition in other countries. Now, we don't have time to go into a lot of detail about potential interventions with informal providers, and that was not the focus of these studies. But I will say that the Center for Health Market Innovations is constantly scanning the globe to look for innovative models that we think can improve the performance of healthcare markets. And we've been looking for the last couple of years to try to find programs that are engaging with informal providers. And we found some, not a lot. I hope that maybe this webinar, through this webinar, we might meet others who are working with informal providers to be able to document more of their programs. But this slide just shows a list of some of the types of engagement we're seeing, which ranges from bringing the informal providers into associations or networks, giving them training and certification, some kind of regulatory practices that work to monitor and oversee the IPs. Interestingly, there's a growing number of programs that are using things like decision support software on handheld devices to help improve diagnosis, also call centers and telemedicine where informal providers can get linked to formal providers or help link a patient to a formal provider, and also things like prepackaged drugs for malaria. And incentivized referrals have been used in a few places, especially I think with traditional birth attendants to try to encourage attended delivery in facilities. So there's definitely some things going on to intervene with informal providers, but there's a lot more that could be done on this front. Again, as an aside, there was a great study published by David Peters and Nirali Shah about a year ago that looked at the literature on what is actually working with informal providers. And they found the vast majority of studies were related to training of informal providers, but they found that training alone really didn't have a lot of effect, probably because of the market environments that IPs are operating in. You really need to change their incentives in addition to giving them training. So that's another interesting study to check out. So I think one of the most striking things about looking more deeply at informal providers and informal markets for many of us who work in this area is to recognize that this issue of informal providers actually relates very strongly to a number of other global health issues that are getting a lot of discussion right now. But interestingly, often informal providers are left out of that discussion even though they're so highly related. For example, take the issue of human resources for health. There's lots of people around the world that are concerned that there aren't enough human resources to deliver health care in developing countries, and there's a number of initiatives designed to try to train more qualified doctors, to get them located in rural areas, or to train more community health workers. But I think there's a question about the fact that we have this large cadre of health workers that are already there, and can those people be leveraged and considered in this discussion of human resources for health? There's a lot of folks that are concerned about poor quality of medicines, irrational drug use, and also making sure people get essential drugs. And we understand that in a number of countries, a key source of pharmaceuticals for the poor is informal providers. So if we're going to address any of these issues related to medicines, we're probably going to have to address informal providers. And there's a whole group of folks that are thinking about health financing, trying to figure out how to reduce out-of-pocket spending and move toward universal health coverage. Well, we understand in a number of countries that a big portion of out-of-pocket spending is on drugs. Much of the drug spending is going to informal providers. Clearly, in thinking about how to create a system for universal health coverage, we have to consider this existing delivery system that's out there and how they are going to be linked to that system. If we build up a formal system around them, will everyone just leave and start going to that formal system? I don't know. I mean, some of the evidence we found suggests that that might not happen, or at least it might take a long time. So I think it's important for all the folks that are focused on these major global health issues to begin to think about how to integrate the question of informal providers into all this. It's clearly a really challenging question because it is hard to influence this group, but it maybe need to be one that needs to be addressed. So in terms of our next steps, we, of course, would like to publish this work. Meenakshi's already got a paper in the pipeline for publication. Our other study authors are working on it, and we're also working on a broader synthesis paper that will further flesh out these themes that I've shared. We also would ideally like to move forward with more action steps around this if we can raise some additional funding, such as policymaker engagement in select countries, convening a community of practitioners that are working with informal providers to share promising practices. And we'd like to do some more engagement with the community that's working on human resources for health and frontline workers to see if there are some potential synergies and opportunities to collaborate. Hopefully some of you that are on this webinar today might become potential partners in this. And as I close, I just wanted to note again that there's a lot of other really interesting studies going on in this area. As Jerry mentioned, the Future Health Systems Consortium is doing a lot of really interesting work in the field to learn more about how to engage with informal providers. And we're hoping to find more people that are interested in this and working on it. So I'd now like to turn it over to Meenakshi Gautham, who is going to tell us about some really interesting findings from her study in India.
I'll be telling you about this study on informal providers in 2 districts of India. We conducted this study during late 2011 and early 2012. There were 2 implementing organizations, CRENIEO in Chennai in India, in southern India, and there was Tehri Garhwal, GCDWS in Tehri Garhwal in the north. So I'll begin with a brief background. I'll describe our study processes, and then I'll discuss the results and their implications. I'm starting with a general background because I really wish to emphasize the need to go in for this detailed study of informal providers. And I will use a few findings from some of my other studies to highlight the rationale for this present study. Most of you will be familiar with this background, but this is really for those who are not. Right. Now, if we look at the demand side in India, we find that informal providers, sorry, it jumped to the second slide. Yes. So if we look at the demand side in India, we find that informal providers are a very frequent source of first contact healthcare. And I illustrate this with household survey data from a few of my previous studies. In this study, which was also set in Andhra, like the present one, but in different districts, we found that 94.8% respondents said they had approached allopathic practitioners, the ones who give biomedicine, and they were mostly private ones in the same or nearby villages. We found that these providers were really informal providers who did not have a medical qualification, and in fact at this time we had not even begun to use a terminology for them, which we did eventually. And when we did, in the next state, which was Bihar, we found that an overwhelming majority of respondents seeking curative health care at first contact sought this care from village practitioners. So here you can see this big blue bar showing that 90% people had sought care from the village practitioners who were informal biomedical providers. But at the same time, India being quite a huge and diverse country, we have also found evidence of this diversity among health providers. And Gina talked a little bit about this in her presentation, and here is some actual data which we found in our survey in Orissa. In a couple of very backward districts, we found that large numbers of people sought care not just from informal biomedical practitioners, but also from traditional healers. And we also found that government non-physician staff like pharmacists, nurses, and health attendants also provided private for-profit services, just like informal providers. So the background is this, that if we were to put all the many different frontline health workers in India into different boxes, we will probably find that the box which has the largest number will consist of informal biomedical providers. So therefore, that's a very significant rationale for this study, which I'll be talking about now, which was conducted in 2 districts in 2 different regions of India. District Tehri Garhwal in the state of Uttarakhand in the Himalayas, and District Guntur, which lies in coastal Andhra Pradesh in the south. I have this little description comparing the 2 districts based on secondary data. As you can see that the 2 are very different geographically and demographically. Tehri was much more rural with a low population density, and the majority of villages had small population sizes, and they were small and scattered all over the hillside. Interestingly, adult literacy in the 2 districts was not very different, and if we go by monthly per capita expenditure as proxy for household wealth, it could probably be higher in Tehri. We couldn't get specific data for Tehri, but we did get for the state of Uttarakhand, where it was higher than MPCE in the state of Andhra. But we found that IMR is still higher, much higher in Tehri as compared to Guntur, and there were absolutely no medical colleges in Tehri as compared to 3 in Guntur, in just the district. Our study objectives began with attempting to identify and enumerate not just informal providers, but also public and private, available public and private doctors in the study areas. The reason why we didn't enumerate the other health workers is because we do not find that other health workers like ASHAs and ANMs are sought for clinical care the way that informal providers are. So the real comparator with clinical care was the doctors. We also wanted to document some basic background and characteristics of the informal providers. We wanted to assess their knowledge and skills, explore their relationships with the formal health system and formal providers, and use all this information to explore and analyze barriers and supporting factors in the process of integrating informal providers. Our study, we implemented this study in all the 9 blocks of Tehri. Tehri has only 9 blocks, and in Guntur we selected 9 out of 57 blocks by stratifying them into 3 different clusters based on levels of development. In Tehri also we did this clustering for our analysis. So just to give an overview of our study processes and methods with respect to the objectives, for provider enumeration we used key informant interviews to identify the most popular and most approached providers, and then when we began meeting with these providers, we used a snowballing technique. We had a structured interview questionnaire to interview all of the providers whom we mapped in these 2 districts, and we had questions on their education, training, practice characteristics. To assess their knowledge and skills, we sampled 100 providers in Andhra and 90 in Tehri. And for the knowledge assessment, we conducted interviews and it's again jumped. Yeah. And for the skills assessment or the performance assessment, we used an observation tool, again with the sampled IPs. And we had in-depth interviews with the sampled IPs, their associations, professional doctors, and administrators. So we chose 3 conditions for knowledge and skills assessment. that IPs said they dealt with most frequently: fever, diarrhea, and respiratory conditions. We had a team of 3 physicians who reviewed the WHO protocols for management of these conditions in adults and in children, and we converted these into knowledge questions with scores based on the number of correct responses for each question. We used similar items similar to the knowledge items, in an observation tool that we used to observe the first 3 consenting patients that spontaneously presented for each of these 3 conditions. Thus, we had 9 patients per provider. And here is an example of how the knowledge questions tallied with the performance items. This is an example from the diarrhea questions, where we asked about the physical examination that would be performed for diarrhea, and based on the number of correct responses, we gave a score, which is mentioned below in the left-hand column. And for the performance items, we observed for these if these tasks were performed or not by the IP. Now, the results, I start with the distribution of the numbers and the distribution of informal and formal providers in these 2 districts. We looked at this across the different block clusters in the 2 districts. First, we found many more IPs as compared to doctors everywhere, and that of course was expected. The ratio of IPs to the population was, you can see here, 1:2299 in Tehri and 1:1941 in Guntur, while that of doctors was 1:9599 in Tehri and 1:5412 in Guntur. Now, on the face of it, this may look quite good, but actually the range for this was much wider for the formal doctors than it was for the informal providers. So, for example, between the least development blocks to the highest development blocks, the ratio of informal providers to the population varied from 1 is to about 1800 to 2000, whereas for the doctors it varied from 1 is to 3000 to 1 is to about 23,000 in Tehri and about 1 is to 16,000 in Guntur in the least developed blocks. Second, we found that there were only 5 private doctors in Tehri but 108 in Guntur. One would have imagined that there would have been fewer informal providers in Guntur because there were more doctors there, but this was not the case. It was not an inverse relationship. So you can see that, even though there were more doctors per 100,000 population in Guntur, we also had more informal providers per population as per 100,000 population as compared to Tehri. However, when we looked closer at the 3 different block clusters, we found the trends somewhat reversed once again. In Guntur, the highest number of IPs per 100,000 population were in the least developed blocks, where there were also very few doctors, and this was an expected inverse relationship. But in Tehri, we found that the greatest number of informal providers were in the highest development blocks, which also had the highest concentration of qualified doctors, both public as well as private ones. So we saw very different market situations in both these sites. We found many other differences between IPs at the 2 different sites. The first one was a huge difference in their education and types of training. Tehri IPs were much more educated. They had more number of years of schooling, and more than 90% had a health-related diploma or certificate, usually a diploma in pharmacy or in something called electrohomeopathy or some sort of integrated medicine, but none of these are recognized qualifications for clinical services in India. On the other hand, in Guntur, we had only 35.6% who reported any kind of diploma, but all of the ones in Guntur had worked as apprentices under a doctor, usually a qualified doctor with a university degree, and they had also served longer years of apprenticeships than Tehri IPs, 7 years as compared to 4 years, with a mean number of, with a mean of 13 years. IPs in both districts had very strong local roots, and this is a very important feature which is emerging over and over again in many studies, and I think it gives us a very important message about the supply side at the first level of healthcare. We in this study also, at both the sites, we found that the majority belonged to the same block or to the same district or to the same state. Only in Tehri we found that about 20% had interestingly coming from other states like UP and West Bengal. We found that IP practices were also quite different across the two states, across the two districts. Nearly all the Tehri IPs were clinic-based, but those in AP went from house to house delivering mobile doorstep services. And even those who had small clinics went around on rounds on a routine basis. But whether they were clinic-based or mobile, they lived very close to their working areas, to their workplaces. The mean distance from the residence to clinic for the clinic-based providers was 2.3 kilometers, and the mobile providers went around in a radius of about 2.1 kilometers. And I think this is the key to their long hours of availability. They live and work in the same, almost in the same area. And another point was that clinics in Tehri were located close to villages, but they were not necessarily in the village or one per village. They were located in marketplaces which could be approached by neighboring people and which made a lot of business sense for the providers. So here is a mobile provider in AP going about his rounds, and in his own words, he goes from village to village, house to house, ringing his bell, very much like a vendor of other services. And here he's sitting in a small clinic. More about their practices, we found that Tehri IPs had a smaller catchment area and fewer patients, obviously given the distances and the low population density in Tehri. They usually dispensed all medicines from their clinics rather than prescribe, and about 50% said they used a blend of allopathic as well as non-allopathic drugs for treatment. Guntur IPs, on the other hand, said they prescribe, sorry, it's again jumping a little, yeah. So Guntur IPs said that they mostly prescribed, even if they dispensed a few drugs, and 99% used only allopathic medicines in their treatment. Interestingly, when we compared the mean knowledge levels across the three conditions, we found that in spite of the IP's educational and training differences in the two sites, their knowledge levels were quite similar and on the whole reasonably high. They were above, between 65 and 70%, closer, hovering around 70%. So, and these knowledge areas were all to do with protocol-based management of these three conditions. So it seems that they do have some reasonable level of knowledge about primary care. To analyze their performance, we calculated the means of IP's performance scores for management of the three different conditions, and found that on the whole IPs did less than what they said they knew. And we also found that Guntur IPs performed a little better on management of diarrheas and management of respiratory conditions. We found a significance in these differences, but since the points, since the difference is so marginal, I'm not sure if this significance means very much. We are currently in the process of analyzing this more in depth and looking at the various variables associated with knowledge and performance. So far, we haven't really found any conclusive associations, except that knowledge is a strong predictor of performance, and also that all the diplomas and certificates that the IPs said they possessed do not seem to be associated with either outcome, with either knowledge or performance. Now, the biggest difference between the two sides was in their use of medicines. We found a lot more polypharmacy among the Guntur IPs. 71% of their patients had received an injection, whereas in Tehri it was 13%. Patients also received more antibiotics in Guntur, a mean of 1.19 against 0.94 in Tehri, and more patients in Guntur received more than 2 antibiotics, so 30% as compared to 19% in Tehri. One of our biggest findings on IP's relationships with the formal sector came not from our in-depth interviews, but from the simple questions about sources of new knowledge about new treatment procedures and new drugs, etc. Now, contrary to our assumption that medical representatives would be the most important source of this knowledge, we found that in Guntur it was the qualified doctors who were the source of new knowledge for more than half the IPs. And you can see this bright orange bar describes that relationship. Whereas you do not find this color at all in Tehri. In Tehri there weren't really those kind of relationships as in Guntur. In Tehri they talked more about having access to medical literature, like there are some booklets on drugs called the CIMS journals. So that's what the medical journal stands for. We don't really think about the influence of the formal sector on informal providers, but I think our study has enough pointers that there is there are strong relationships which exist both ways, you know, positively and negatively. On the whole, IPs in Guntur had a lot of win-win relationships with the formal sector, especially with private doctors, who, as you may recall in our first results slide, they were found in large numbers even in the medium development blocks. Around half of IPs in Guntur said that they had received some referral incentives from the doctors, but they also said that they had a lot of faith in the technical skills of doctors and they relied on knowledge they learned from them. They had close interpersonal bonds, some dating back to their apprenticeships, and we did not come across any reported hostility from the government doctors either. And some of these government doctors may have also been involved in a state-sponsored training program for IPs, which I'll talk about in my next slide. So they would have actually been trainers of these informal providers. However, IPs also saw doctors as their main competitors, and so there may be a little bit of a double-edged sword about this relationship with the formal sector. In Tehri, the situation was just the opposite, which was strange because Tehri is quite underserved, and you would have expected the state to have done a lot more to capitalize all the human resources over there. But we did not find the same kind of strong interpersonal and referral relationships between IPs and doctors, and a very negative and hostile climate towards IPs. We heard that health department officials armed with government circulars often went around demanding to see IPs' certificates and sometimes asking for bribes to leave them alone. So this was a very different situation altogether. Now about the Andhra Pradesh Training Initiative for informal providers in that state. In 2008, associations of RMPs in the state, which have a long history to them, they lobbied successfully with the Chief Minister at that time in 2008, and the Chief Minister told the various associations that if they came together under one federation and if they were clearly able to articulate their demands under one voice, he would grant them some recognition. And in September 2008, he called together a meeting of all his various government departments and various senior officials, and all met, and they proposed to formally integrate the services of rural medical practitioners into the healthcare delivery system of the state. And I'm quoting their words when I say integrate the services of rural medical practitioners, blah, blah, blah. They would be registered by the plan was that they would be registered by the state paramedical board that was set up earlier in 2006 and given appropriate training. So eligible RMPs were identified and given these kind of I-cards, as you can see in this photograph above. Now the training course was for 1 year, twice a week, culminating in about 1,000 hours of training. The training was going to be limited to about 90,000 IPs who were registered with various different associations in the state. And there are many such associations in Andhra, by the way, almost one per district. And they all come together at the state level in one federation. But there are many who don't choose to join the federation also, but there are many who do. Whereas, again, in Tehri, this is very different. IPs are totally disorganized and they're quite isolated in their practice. So coming back to the training in AP, the eligible IPs for this program were those who had a letter of recommendation from their association, who had 5 years of experience of working under a qualified doctor, and a minimum educational qualification up to class 10. And according to the whole plan, after completing the course, they would sit for an examination based on their ability to take notes on clients' history of the illness, treat acute minor ailments, provide first aid, and provide home care for the chronically ill. And successful candidates would then be certified with the AP Paramedical Board. Unfortunately, in 2010, the Chief Minister died a premature death in a helicopter crash, and with him the program also declined because there were shifts in political will. And in 2011, the training program was closed. So examinations have not yet been conducted. Early this year, we filed an RTI application. RTI is an act in India, stands for Right to Information Act, under which citizens can demand for information from different government departments. So we filed this to the appropriate department, and we learned that 52,000 IPs had enrolled for the training. About 22,000 were trained, but no examination has been held, so no one's really been certified. But the government spent around 17 million rupees on the training. And the State Association of Practitioners is lobbying once again with the political leaders to resume the program. When I look at this slide, it also provides a kind of distinction between the two districts, because the barriers all seem to come from one district and the supporting factors all seem to come from the other district. In terms of the barriers, of course, at the very top we have legal barriers, stating that very clearly, the Indian Medical Council Act does not allow anyone without a university degree to deliver even primary care. And we find that in Tehri, this barrier has been sort of magnified by lack of local support for IPs, both from the medical establishment, which itself is probably not very much either in numbers or their strength, and the local government as well, that does not see the disunited IPs in the state as any kind of political force. All these factors have been kind of turned around in AP because of the strength of the local IP associations, and they've been supported by a progressive political leadership along with win-win partnerships with the private sector. And I think this plays a very important role in strengthening the climate for developing interventions. However, we have also seen that without political willingness, all the other factors seem to decline in strength. However, the AP initiative can be a very useful example for other states who want to develop similar experiments. And I think that we as community, as a health community, can do our bit to support the movement, and we are doing just that with all of our research and networking and discussions for the future of this sector. The main conclusions are that IPs, even though they are on the margins of institutions, they are firmly institutionalized in the primary healthcare scenario in India, but their role has evolved very differently in different contexts. And so perhaps there can be no one-size-fits-all solution in terms of engaging with them. I think they will continue to play this role for a very long time, even in places like Guntur, where there is better infrastructure and more doctors in general, but villages are still underserved. So we'll need to address both short-term as well as long-term strategies for addressing this demand and supply market. And interventions will need to move beyond training and address issues of performance and certification without which they will not be sustainable. The example from Andhra shows that a lot is possible at the state level if states take the initiative and join hands with private organizations rather than one national level body taking on this whole task. States in India have a fair amount of autonomy, and if they do want to develop their own innovations, they can do so, as the Andhra example shows. Finally, and I think that the role of the state is really very important, because as far as certification is concerned, the state can lend an umbrella recognition which private organizations perhaps cannot. So it's important for the public and private sectors to work together for sustainable interventions. And no intervention would be sustainable, I feel, without appropriate certification. The other things, of course, come in later, regulation and quality issues. But for all of these, for the IPs to want to deliver all these, they need to have a very clear interest in front of them, and that comes from their ability to function without being harassed and having some kind of legitimacy. Finally, I think that the universal health coverage paradigm provides a very good umbrella for designing interventions, because this framework keeps people's health needs right in front, and it forces us to look beyond just the supply side to the demand side as well, and see what messages are coming from both sides and how we can think of different types of strategies and interventions, both short-term and long-term. So in the end, a big thank you to my fantastic teams. I know that they're all listening in right now, so thanks to all of you. And I hand the microphone over to the organizers to handle the questions.
Hello, this is Jerry Bloom again in Brighton in the UK. First, I'd just like to encourage other participants, and I notice we still have 77 attendees in this seminar. You're certainly welcome to use the chat function to send questions or comments. But I have a couple questions, and I thought I would pose first some questions to Meenakshi, and then after she answers, to Gina. So there were a couple questions came for Meenakshi. The first asks a question that implementation of regulations and assuring quality is a big issue, and I think everyone agrees. But who are the providers who will see that they should follow these regulations? What are the lessons? And I guess the big question for you is, how many of the informal providers do you see as likely to be willing to work within a regulatory environment? A second big question was saying, well, yes, it's clear that informal providers can play a role in improving the health of people living in rural areas, but this will need coordinated action. And the questioner mentioned regulation of the pharmaceutical industry, education programs for informal providers and licensing, monitoring of compliance of informal providers. And the big question is, in India, which organization or which organizations are capable of taking on all these interventions and regulations at large scale? And a particular question was asked about the role of non-government organizations for training, in particular community-based volunteers, but also informal providers. And perhaps when Meenakshi answers this and wraps up, she may reflect from her own point of view, or what are the next steps in research and engagement with these stakeholders to have large-scale change. So I'll turn over to Meenakshi.
Okay. Do I have the mic? Yes. Yes, I do. So the first question, actually all these questions are quite closely interrelated. They're about really about what next and how are we going to do it and who will do it. There are several issues around regulation. One is that we're talking about not just informal providers in isolation here. We're talking about a larger scenario where informal providers are embedded in a climate, in an overall climate of poor quality. A lot of their knowledge and a lot of their influence, a lot of the influence on their use of drugs is coming from the formal sector. So I think that regulation in isolation just for informal providers will have only limited success unless we are willing as a, you know, as civil society to confront this issue of overall poor quality of healthcare in India. It's not just about informal providers, it's about all providers. You know, all of us as patients are exposed to poor quality care for many different reasons. So let's start addressing this in a comprehensive way. At the same time, let me also say that if we want to focus on informal providers, we have to take a lot of their interests into account. If we want them to restrict their polypharmacy, for example, in a very concrete, as a very concrete first step, then if we make demands like limiting their drug use to just you know, non-prescription drugs, which are very, very limited, that might be quite unrealistic. So the first step in this process might be to work out some kind of rational drug use which they can use, including some antibiotics. You know, we can't be so touchy about use of antibiotics by anybody who's not a doctor. And we are having a lot of issues around this with the medical community in India. We are trying to you know, the medical establishment is so much against any kind of clinical practices or services by anybody who's not a doctor, which is not a very practical position. So I think we have to be realistic about what are we trying to regulate, what is really harmful. So that would be the first step. And that will also meet with the interests of the IPs, because let's not forget that they are not voluntary workers, they're doing this for a living, so their financial incentives have to be worked out, and their drug dispensing or drug use has to be within some kind of a pragmatic framework, not something which is very idealistic. The third point is that I would like to look at these strategies fitting into a long-term framework of streamlining this market, and one possibility might be to link informal providers with other developments going on in the country. We have some steps, a lot of steps are being taken towards developing mid-level practitioner programs in the country who will be trained, who will be recruited from rural areas and trained over 3 years. And a whole lot of, a curriculum has been worked out, and registration systems and regulatory frameworks are being worked out for that program. So it would be really worthwhile to try and see how we can integrate informal practitioners into that system, which provides a pre-existing scenario. As far as which organizations are capable, again, I think that we need to decentralize this whole program, stop looking for single national bodies who can take forward any interventions, but promote state level examples. Health in India is a state subject, so the states know about what their own problems are. And as you can see from our study, we have very different findings from 2 different states. Each will require its own solutions, which they have to work out by themselves, and if they can do it through some kind of public-private partnerships within the state, draw in NGOs, draw in medical institutions, maybe hospitals, maybe medical colleges, who can do the certification, and some kind of a recertification process can be worked out with them with constant monitoring, while the state provides an institutional framework to certify these providers. That might be a possible way forward. So with that, I'll conclude my answer. Jerry, over to you.
Hello. I think I will now put a couple questions that came in for Gina, and we may, if we have time, come back to some more questions to you. Essentially, there were 2 questions that are interlinked. I guess the first is, as you focus more, as you said you would, on interventions, what kinds of partners do you anticipate engaging with? And there was a specific question on the role of international NGOs. Given that they don't usually have a legal mandate to influence quality, how can they become engaged? And the second question is asking about your ideas to expand them on how you could bring research findings to influence policy and to inform policymakers and potential innovators. So I'll pass over to Gina.
Great, thanks so much, Jerry. 2 really important questions, and also I have some ideas, but these are the kinds of things I'd love to talk with more of the people that are involved in this call on how we could best go about this. But I do think that there are a number of international NGOs that are already working on this issue, and if we look at some of the more successful programs out there that have been working with informal providers, you can see that there are international NGOs involved. A great example that we haven't touched on yet, because it's in Tanzania, not India, is the ADDO program, where Management Sciences for Health, MSH, collaborated very closely with the Tanzanian government to create a program that began to license the drug sellers and provide them training and do oversight and make a number of interventions. And there's been some positive findings to the evaluations of that program, and now it's being copied in several other African countries. So I think that's one example. I think the example of World Health Partners and its programs in UP, India, and in Bihar, where it is working with some funding from the Gates Foundation and other funders, and I think in some collaboration with the governments, to begin utilizing informal providers to deliver care, and also linking them through telemedicine models to qualified doctors in cities. That's another example of an international NGO that is creating programs. Jerry, some of the programs that that Future Health Systems has supported in Bangladesh, working with the ICDDRB, the Shasta Sena program, that's also something. A number of these have been driven by private NGOs, where there's been attempts to organize, train, change the incentives, provide different technologies to informal providers. My sense is that if these programs are done in collaboration with government, they're probably likely to be more successful, although we've seen some examples in places where we've been more associated with government and some with less associated with government. In terms of what we would like to do, I mean, to be honest, we don't have yet a lot of funding right now to continue this work in this area, but we are hoping that we can, with the publishing of these findings and some of the other really interesting findings that are just coming to light, some of the other studies I mentioned, we're hoping to get some donors interested in supporting more work. We do think there is potential to bring together practitioners who are engaging in these programs with informal providers around the world to begin to share good practices. It would be great to bring some of the folks from Andhra Pradesh together with some of the folks in Tanzania and Bangladesh and start to learn from each other and figure out what may be working. I think in terms of your second question, how to engage more with, I think your second question, Jerry, was about engaging more with policymakers globally and in countries. Am I recalling that correctly?
Yeah, yes. And more generally, how you see bringing research findings to people who can act on them.
Yes, I think that's a great question. I think, obviously forums like this are a start, but we need to get to a different kind of audience that probably aren't going to be participating in a webinar like this. Meenakshi and I have already been in conversation, and I know she's been talking a lot with many of her colleagues in India about trying to do some, to host some dialogues, both with the union, the central government in India, and also potentially in some states. And one of the ideas, and she can speak to this more, was to maybe bring some people who've been active in states where there have been programs to work closely with informal providers, bring some of those people together with policymakers from other states as well as union policymakers to have, for them to learn from each other and have more discussion and hopefully spur some activity and some thinking. I think that there's potential to do this also in other countries like Bangladesh, Nigeria, and other places where there are large concentrations of informal providers. Probably for a lot of action to really happen, it has to happen at the national or even local levels or state levels, as Meenakshi suggested. But we think there could be a better enabling environment created for all of this if there was actually more discussion at the global level too, with some of the major technical agencies like the World Health Organization. We have had some interest from people at WHO, but I think it would be good, and our hope is to continue to engage with various international groups to raise the awareness of this issue. And I actually think that one way we might do that is by linking with some of these other agendas that already have traction, like human resources for health, like frontline health workers. I've already been approached by people in some of those groups who've said they would like to begin to collaborate, and so it's a goal over the course of the next few months to try to reach out more to people in those groups, share these findings with them, and see if there might be potential to collaborate to raise awareness of the issue of informal providers with global policymakers and opinion makers.
Okay, there are a couple more questions that were raised, and I think I would ask them. Some are more directed at Meenakshi, and one of them would be good to get both of your points of view. First, the question for Meenakshi really was the reasons for your choice of the two districts, and what are the implications of the different findings for strategies and policies in India. And then a question about the different types of informal providers in terms of training or the type of healthcare they provide, and what are the implications. One other, I guess, two questions that are connected. One is, it seems that informal providers in India are providing antibiotics outside of the law, but to what extent are sanctions used if they do prescribe antibiotics? What does it mean to be outside the law but not penalized? And a question about, given the fact that informal providers tend to rely so much on earning money from drugs, are there examples where governments have engaged with them, brought them more towards the public system without leading to major increases in drug sales? I wonder if we could ask Meenakshi first to comment, and then perhaps Gina can sum up some of the thoughts.
Okay, those were several questions, and I've been trying to take notes to be able to recall them correctly. Okay, let me start with
The first was about the choice of the district.
Okay, the choice of 2 districts. The mandate before us was to have 2 different sites, which would be fairly different from each other. And so we decided to go for one in the north and one in the south. In the north, and I have to say that these were both purposely selected in some ways. Tehri Garhwal is a district, it's definitely one of the more backward districts of Uttarakhand. There are difficulties there, and I had done work there in the past, and we had a local presence in the district. So given our limited resources and the limited time that we had at our disposal, about 11 months, it would have been very difficult to select a district where we had absolutely no presence at all. So we went with Tehri Garhwal in the north. In the south, our broad selection states were limited to Andhra and Tamil Nadu, because we had access in these 2 states. But Tamil Nadu, we felt that because it has one of the best performing health systems in the country, we may not find informal providers to be as widespread or as significant a source of healthcare. So we chose to do this in Andhra, and we chose a district which was fairly rural, but at the same time had better infrastructure, and it had we did some sort of prior discussions with local stakeholders and some key informants to zero down on this district. So so the choice of these 2 districts was really based on a combination of a purposive selection along with a fairly strong rationale which would give us enough differences and enough variation in the geography, in the demography, and in the kind of markets that exist. So yeah, so they're certainly not representative for every place, but what these districts do suggest is that markets can be very different in different regions. Now, what was the next question, Jerry? Something about implications for training.
Well, no, I mean, there was a question about the different types of informal providers in terms of the type of practice they had and what are the implications about allopathic, Ayurvedic, etc. Or did your study not look at?
Yes. No, we had as I showed in one of my background slides, there is diversity in India. You will find that there are of course the qualified medical doctors. Then you have the unqualified providers who do allopathic medicine, that's our informal providers. We also have traditional healers of different types. We have folk healers, and we found them in Odisha. In the northeast, we have traditional practitioners who follow local traditions in medicine. They use a lot of herbal medicines, but again, they do not have any formal qualifications. So they are they're not exactly informal also, but they do have some kind of tradition of learning which is not institutionalized, but it exists, and they practice traditional medicine. Then we also have a professionalized we have different professionalized non-biomedical systems of medicine in India, which is Ayurveda and Unani and Siddha and homeopathic medicine, and we have a whole government department called Ayush to look after these systems. Ideally, these professional non-biomedical practitioners should be dispensing or should be treating using the pure form that they have been trained in, but what we have seen from other studies, not this one particularly, but in other studies we have seen that there is a mix of medicines that is used, and even the ones who are trained in a non-biomedical system end up using biomedical medicines. In our study, we found that in the villages we did not find in fact any of these pure professionally qualified non-biomedical providers. So it's not just the qualified doctors who are not able to go and work in villages, but it's also the other non-biomedical providers, the professional ones, who do not see much business sense in going and working in underserved areas. So it's largely left to informal biomedical providers. And as far as training is concerned, I think that, you know, we have to align the competencies with what people require at that level. So all of them should be able to provide a basic level of health care for people at the first level, which includes, you know, basic management of conditions which present at that level. And from our study, we know that knowledge itself may be, you know, reasonably high, but it's the performance that we have to work on, and that's going to be the real issue perhaps in future studies. We need to look at how we can improve performance of adhering to protocols, and one way of doing that might be through using technologies. I've had some other experiences in my work, using technologies in healthcare, and we find that if we use procedural guidelines on, say, mobile phones, that might help people to adhere more to step-by-step guidelines. But you know, these kind of programs have to be incentivized and all. So you know, that would be my response to training. I'm not sure if I've addressed it fully or completely, but that's what I understood of the question.
Okay, and I think there's one last question which I suspect both of you could address, and then I think we're coming to the end. I guess the first is, you find that the informal providers are using lots of antibiotics, but it sounds like this is outside the legal framework. Are there sanctions for people who prescribe antibiotics, and why are they not applied? And I guess more generally, given the degree to which informal providers depend on the sale of drugs for earning a living, how would you see the risk of greater engagement by governments or others? And are there examples where substantial interventions have taken place where they've avoided the problem of acceleration in drug prescription? And I suggest Meenakshi make comment, and perhaps Gina as well.
Okay, fine.
Do you want me to start, Meenakshi, and then I'll let you?
Yes, that's what Jerry said. So I'll wait for you to
I'll
finish.
leave the question of antibiotics to you, Meenakshi, because I think you know more about the context of India and what's been happening in terms of potential sanctions. But the second question, Jerry, about government coverage of drugs provided by informal providers is a really important one. And I think, you know, as the question alludes to, we know that the minute you start to provide financial coverage or reimbursement for a particular service, especially something like drugs, the consumption goes way up because obviously suddenly it's even cheaper for people to get those drugs. And we know that there's already a rampant sort of overconsumption of certain kinds of drugs. So I think it would be quite risky for governments to sort of create blanket coverage for drugs provided by informal providers or even formal providers. And in other work that I do, I work closely with governments who are in low-income countries that are trying to create national health insurance programs. And today, there are relatively few of the national health insurance programs that are emerging in lower-income countries provide drug coverage for this reason, even through formal providers and formal pharmacies, because they're worried about overconsumption and the costs increasing. So I think this is a big challenge because we know that these programs are trying to reduce out-of-pocket payments, and we know a lot of those out-of-pocket payments are currently going to drugs, but if you begin to cover the drugs, then you might see consumption go up even more and costs go up even more. What I think could be a potential answer might be very limited and targeted coverage for certain priority medicines that may right now not be being prescribed as often by informal providers. There might be a possibility to begin to cover certain types of medicines that we know have very important health effects that might not be demanded by the population otherwise, and therefore increase the consumption of those types of medicines, but perhaps not initially cover the cost of other drugs like antibiotics, which we know are overprescribed. But this is a really challenging issue. I think there's a number of folks that are beginning to think about it and try to grapple with it. And it's something that a number of the countries that we work with, the governments, the health coverage programs are grappling with too.
All right.
Yes.
And
Should I come in?
Please. And yeah.
Yes. Thanks, Gina. Yeah. I think my observation would be that we need to understand this phenomena of polypharmacy a little better. I think we're all the time linking it with financial incentives, but that may or may not be the case. There might be other factors influencing polypharmacy. It could be that, informal providers are just trying to show off their knowledge and imagining that, if they know as much about medicines as qualified doctors, it raises their prestige in the eyes of the users. I don't see the case that the more number of antibiotics you give or the more number of injections you give, the financial incentives can keep increasing indefinitely. There is a finite cost to this market. It operates within a certain market range of pricing, which is determined by the market. So providers are all, trying to fit in with the number of drugs that they are giving and what they are charging for those drugs. I think we need to understand that a little more, how that works, how that happens, and what are the variables which influence that, before we can start making some kind of interventions there. I think that this is one issue which cannot just be addressed by the supply side. We also need to look at a lot of demand side interventions, a lot of public education about rational drug use. And I do recall reading some articles about interventions that have managed to reduce polypharmacy in doctors' prescriptions through multifaceted interventions that include some sort of training about rational use of drugs, because knowledge issues might be involved in wrong prescribing. So training programs with a combination of public education as well as some sort of a closed body pressure, which could come from an association or which could come from a voluntary, some sort of a voluntary pressure which can come from, say, a medical association like the Pediatricians Association or the IMA or something like that. So they put pressure and polypharmacy reduces. Similarly, one could use the RMP practitioners associations to try to intervene in polypharmacy. So I don't think it's a very straightforward relationship between use of medicines, wrong use of medicines, and financial incentives. I think there's a lot more going on over there. So, yes, Jerry, that's my response.
All right. Well, I think we've run out of time. There are plenty of questions left to address, and maybe people will want to interact with you. They can get your email addresses or your websites, and I hope we've started a debate that can continue after this webinar. In the meantime, I'd like to thank Gina and Meenakshi for excellent presentations and for providing a high-quality launch of this series of webinars. I'd also like to thank the attendees who have stayed with the discussion for so long. and have dealt with some of our technical problems. I think we now would like to ask your help, because this is the first in a series of webinars, and we will be getting in touch with all the people who have been participating in this webinar and ask them to fill out a short questionnaire to help us continue to improve the quality of this series. And it remains to me to thank the people who behind the scenes have been helping set up the technical aspects of the webinar, and to invite you to join us and register for the next one on the 7th of March. In the meantime, thank you, and in India, good night. In the UK, good afternoon, and in the United States, welcome to, or good morning.
Great. Thank you so much, Jerry. And I also just wanted to note that for those of you that are participating that are interested in potentially getting involved in a global community around this issue, we do have your email addresses since you signed up for the webinar, so we may send a note to see if you're interested in further dialogue. Thank you so much.